Welcome to Med Exam Expert. I'm Dr. Huda. I'm a consultant physician and I'm practicing as a consultant physician at various hospitals. So I welcome all of you to the FCPS Part 2 and IMM course. So I believe all of you would be attempting the February attempt. If you could let me know in the chat box how many of you are preparing for the February attempt. Okay, so we have some answers. Okay, so some of them are giving part 2 in February. What about IMM in intermediate module? How many of you are attempting intermediate module? Okay. And would this be your first attempt or is this your second or third or subsequent attempts? Second attempt, subsequent attempt. Okay. So can all of you see the screen? Is the screen visible? Okay. Okay, so let's start a official discussion. So if you're preparing for your FCPS Part 2, I know this is something very, very exhausting and very dreadful immediately after your residency. Once it's over, then it's very difficult to start preparing for your FCPS Part 2 or in between your training to prepare for IMM. So what we are planning to do for you is that we are planning to do recalls of the different past papers maybe. You cannot discuss the actual papers because the actual questions are not present. They're all recalls that different candidates come back and they share their different recalls. So it's always a better idea to do recalls rather than doing past papers. So before we begin our webinar formally, let's discuss a little bit about the pattern of the exam and the different resources that you can use to prepare for your exam. And I would like to hear your input as well about what you think if you've already given an attempt, what do you think was the best resource that you used, or what do you think could have been better? So in my opinion, if you are preparing for your FCPS Part 2, you should prepare for minimum of 3 months, which is dedicated period. So if you've completed your training, you're sitting at home and you're not really working at any bigger setup hospital, you're just doing a clinic or something, and then you're preparing at the same time, then it could take you somewhere between 3 months to 6 months. But if you're not very good with your basic concepts or you think you've forgotten them, then I think up to a year's time would be good enough. But the key is that during your residency training, it's always ideal to start preparing to keep on studying and not just close all your books and just use internet resources. It's better, it's always ideal to go through your daily cases from a standard textbook. But even if you've not done that, then it's the high time that you start studying for your exams and then use a standard textbook for your reference, and then you can use other resources as well. Then if you've already given your MRCP Part 1 and Part 2, or if you've given any other foreign exam, that would be very, very helpful for all of you because that really encourages you to study throughout. And it also helps you to build up those concepts that would help you later on when you're preparing for FCPS Part 2. But if you've not given any exam, any foreign exam, then that would require a lot of hard work, and that would require you to give a lot more effort than your other counterparts and other peers would do. And then clinical practice, if you are practicing at a setup where you have a lot of patients, if you're doing at a bigger tertiary care public sector hospital, or if you're working at a private sector hospital which has a higher patient load, that would also help you because you will be seeing a lot of cases on daily basis. So that also helps, rather than if you're posted somewhere at a very peripheral kind of a location where you do not see a lot of patients. So then you might not be into practice to that extent. Then about the resources, there's a lot of speculation about what you should use, if you should use any question bank or you should not. In my opinion, and in my peers' opinion, from all the candidates whom I've discussed in the recent on years, they've all agreed to one point that you need to solve any question bank, which is a foreign question bank. And it could be MRCP question bank. So what we suggest, ideally, what you can do is that for your IMM, do solve past medicine at least once. Do your past medicine thoroughly. That would really help you in building those concepts. So if you're preparing for FCPS Part 2, you can revise whatever you've done for your IMM, and then you can add one more question bank from the MRCP Part 2, and that would really help you in revising all of your concepts. It will also help you in problem solving, because on the exam it's no more a writing exam, it's always an MCQ based exam. So if you solve more and more questions, that would really help you in solving questions in a very limited time on the main exam. So it's ideal, if you're still in your training process or you have time before your exam, start solving question banks from the MRCP. And once you've done that, you notice on your own as well that your concepts, your underlying baseline knowledge has improved to a lot more than without doing that. Then after the question bank comes in the examination recalls. Now, if you're doing your residency in Pakistan, you must have gone through all of these different medical bookshops, and they have recalls in the form of big, huge notes. It's impossible to solve all of them because it would take months and months to solve them. And most of the questions there are poor recalls. So the questions there are just incomplete sentences, and there's always discussion and there's always confusion regarding the correct answer. So instead of going into the confusion of those recalls, I would recommend that you can use those recalls as learning tools. Whenever any of my students ask me, I always tell them, use your examination recalls as learning tools. We'll see, I'll go through different questions and I'll tell you how you can utilize those recalls. So in a very limited amount of time and with limited resources, you will be able to revise all of your core concepts that would really help you to clear the exam. And then the last thing, that is the notes or the current medicine. Again, you have to use current medicine as a part of your learning routine. You cannot memorize the entire current. It's huge and you cannot never revise it before the exam. But the way to do it is that at least for the cases you think that are important as far as the exam is concerned, make notes for them, because that will not only help you with your theory exam, it will help you with your talks, it will help you with your cases, short and long cases. For example, if you get a case on lung cancer, if you have your notes ready with you, you can always revise those notes before your exam. When you're practicing for your clinicals or you're practicing for your short cases, you can always revise them. And within a few minutes, you'll be able to revise the entire current. Instead of trying to go through the chapters again and again, it's ideal if you make your own notes and just revise them a few days before the exam. Okay, so these are the different resources that you can use. So any opinion, any discussion, any input that you would like to add as far as the resources are concerned, or would you like to add any other resource that you've used for your exams and you thought that was helpful for you? So we can discuss that as well. Or if you would like to add anything else. Any opinions, any suggestions regarding the resources and the preparation time and how you would be utilizing your preparation time? Okay, one more question is when you should start the recalls. Okay, so at least start solving your past papers or your recalls at least a month and a half before the main exam, because that does take a lot of time. In the beginning, when you'll start solving it, if you solve, it would take you 2 days or maybe one day per paper. But then once you start getting the questions repeated, then that would make it easier. Saffron series. Okay, Saffron series, again, Saffron series is a very good resource. You can use Saffron series. It has a very good um, understanding of all the questions. It has a lot of recalls also, and the questions are very nice. You can use them as a learning tool. If you're using, instead of solving the entire past papers, if you don't have time for that, you can always solve Saffron series. That's a really nice book. The Wisdom series, on the other hand, has a lot of mistakes. So if you do not have a lot of time to sit down and correct it, then that would be a problem for you. But the Saffron series is pretty much accurate. You can always solve that. MRCP one question bank is enough for part two medicine or two? No, one question bank is not enough. The MRCP part one question bank is enough for the IMM. But for FCPS Part 2, you need to do two question banks, one from MRCP Part 1 and one from MRCP Part 2. Because the MRCP Part 1 is more of pathophysiology and diagnosis, but the management part generally comes in MRCP Part 2. So you need to do both. Okay. Anything else? Any other question? Okay. Then we can come on to the resources again as well. So I think you must be knowing the pattern of the exam, that the exam is all question and answer based. It's an MCQ based paper and it will be on your laptops. So you'll there'll be a laptop in front of you and you have to click the answers. The questions will be repeated only once. So if you skip a question for the first time, you will not be able to skip it again. And once you've marked the answer, you will not be able to answer or you will not be able to change the answer either. So once you've thought of a question, you've marked the answer, be very thorough in reading the question. Be very careful when you're marking the answer because you will not be able to change it. Are the MRCP2 question banks on MedExam Expert the same as past medicine? No, they're not the same. They're not identical, but they're very similar. Okay. They're not identical. But the main concepts, all of the core concepts are the same. Okay. Okay. Now, I'll be going through one question from each system, and then we can see how we can solve the question in a very effective way. Even if you have not revised the entire context, or if you don't remember it at that point in time, how will you use that information that is given in the question in order to solve the question? So I'll help, and you have to do that in a minute or 1.5 minutes time because you have very limited time to solve the question. So let's go through each question and then we'll see how we can make up with all of the information and come up with the correct answer. And how would we would be using our examination recalls. Okay. So this is the first question. I want all of you to go through it and go through the question, and then we'll see what is the important information that has been given in this question. You have a minute's time to go through the question. Okay. So you have a 67-year-old retired builder who comes to the respiratory clinic for review. He has been diagnosed with asbestosis and has progressive shortness of breath and decreased exercise tolerance. He smokes 20 cigarettes per day. Examination reveals crackles consistent with pulmonary fibrosis and some wheeze consistent with chronic obstructive pulmonary disease. So they're talking about a builder who has been diagnosed with asbestosis and COPD. and he's a smoker. Now let's see what the labs are telling you. So the hemoglobin is 14.9, white cell count is 7. The platelets are 231,000, sodium is 144, potassium is 4.3, creatinine is 95. The chest X-ray shows multinodular opacities and pleural plaques. And then the CT is telling you subpleural linear densities, basilar and dorsal lung parenchymal fibrosis, peribronchiolar, interlobular, and septal fibrosis. So that's all of the extensive information that the question is telling you. Okay. Now, what is the question really asking you? So they're simply asking you what is would be the following measures which will be the most effective to slow down the progression of the fibrosis. So what do you think is the correct answer?
Smoke cessation.
Okay. Let's see what the others have to say. Okay. Okay, now let's see what is the important information that this question is telling you. So, whenever you're reading a question, always look out for the important information that the question is telling you. The age, very, very important. So, it's a 67-year-old man. So, always think about the conditions which are related to older age group population. Then the profession. The patient is a builder. Okay, so he's a retired builder, so exposed to silicosis, exposed to asbestosis. They always want you to know something about occupational lung diseases whenever they mention the profession. Then, where is the patient coming to? The patient is coming to a respiratory clinic. So they want you to narrow down the differentials. Now, once you've started, even in one line, you will be able to narrow down your differentials. And now he has been diagnosed with asbestosis, with shortness of breath, and COPD. So now what is the question telling you? That he has two different diagnoses. Now you know that asbestosis, the lung fibrosis associated with asbestosis, is not really reversible. Okay, there's no such risk factor that would help with the prevention or with that would stop the progression. But you know about COPD, that the progression would be decreased, or you can slow down the progression of the disease by doing what? What is the most important thing that you can tell the patient to do in order to decrease the progression of COPD? All of you answered smoking cessation. So yes, that is the correct answer. It's smoking cessation. So patient who smokes associated with asbestosis, they have a very high risk of developing lung disease. But if you stop the patient from smoking, if you counsel the patient regarding smoking, that would really help the patient's long-term prognosis. Now, this was an example of a recall, the kind of recall that you would get on the exam. You may or you may not be able to understand the entire stem just by looking at it. It might be under incomplete stem. Maybe the person who came out and who wrote the question forgot to write about COPD, but knew that the answer was smoking cessation. So if you just look at the question that asbestosis is associated with smoking cessation, that would be the wrong answer. But just the way when you've read a question like that, keep in mind that it could be asked in many different ways. They could have asked you, yes, this was a recall MCQ. So they could have asked you in different ways. For example, they could have mentioned about builder, and they could have mentioned about plaques, and they could have asked you about the disease. So it could have been asbestosis. Or maybe they could have given you the clinical vignette, and they could have given you the CT findings and asked you what could have it been. Or they could have told you that this was asbestosis and COPD. What would you find on the CT scan? So it could the same question, or what would you find on spirometry? So the same question could have been asked in various different ways. So if you study about COPD thoroughly, if you study about asbestosis thoroughly, you will be able to answer any question that you come across in any form, whether you get the treatment, whether you get the diagnostic criteria, whether you get clinical features, anything of that sort, you'll easily be able to come up with the correct answer. So if you see a question like this on your recalls, what would be the most important high yield topics that you need to see in detail? So you could be asked about occupational lung diseases. It could be asbestosis, it could be silicosis, coal workers disease, it's always important to know about the different occupational lung diseases. It will always be asked in different ways. Then about fibrosis, the all of the interstitial lung diseases, diseases associated with fibrosis. What are the diseases that cause apical fibrosis? What are the ones that cause basal fibrosis? Very, very important to know about all of these conditions. Then COPD, extremely, extremely important to know about COPD. The pathophysiology of COPD is important, the diagnosis, the complications are very, very important. Then about the long-term oxygen therapy, non-invasive ventilation, core pulmonale, all of the complications that the patient can develop, extremely important. If you've seen a question of COPD on your recalls, it's absolutely essential that you know each and everything about COPD, because you can be asked in various different ways, and not only in your theory, you can be asked in your talks, you can be asked in your clinicals. So while you're preparing, it's always a better idea to prepare thoroughly, because it will not only help you with your theory exams, will also help you with your clinicals when you move ahead. And then smoking cessation. If you come across anything regarding COPD, it's always important to know what are the benefits of smoking cessation, what are the methods. So very, very important to know about that. So that is how you would be using your recalls. So even when we are doing our recall session, when we will be doing our workshops, if we come across a question of asthma, for instance, not only we will be doing the diagnosis of asthma, we will be going through the guidelines, the latest guidelines. We will be going through the complications, the spirometry findings, everything and anything that is related to asthma. We will be covering it in our recall session. So very, very important to know about that. I'm really sorry. There was some problem with the internet connection. Um, am I audible?
Yes, ma'am.
Okay. Okay. Okay, so we were discussing about the recalls and how you will be using your recalls effectively so that once you do any question, you are able to understand the entire topic out of that question. And next time when you come across any question regarding that similar topic, you would be able to answer very, very correctly. And you don't really need to go through all the question banks, all the recalls again and again. If you've solved 2 or 3 papers of the past few years, I think that would be sufficient for your preparation. Now let's see the next question. Then again, when we do that, we'll be seeing what different topics can you extract from just one single question. Okay, so this is your question. Again, very, very important as far as FCPS Part 2 is concerned. In FCPS Part 1, you do have the option of choosing which systems you want to attempt. So paper A would be a complete mix of all of the systems, and part B of the exam would be you have cardiology compulsory, and then you can choose 3 different systems that you would like to attempt. But in FCPS Part 2, you do not have the choice to do that. You have to attempt each and every question that you'll be shown on your screen. So as far as FCPS Part 2 is concerned, rheumatology, nephrology, electrolyte imbalances, endocrinology, they're extremely, extremely important. And somewhat we overlook them while we are preparing. All of our focus is on cardiology and respiratory medicine and gastroenterology. But most of the candidates who find it difficult to pass the exam, they do come up and tell us that it was because of probably nephrology and electrolyte imbalances or endo. That was the main problem where they got questions wrong. Okay, so let's see the next question. So you're reviewing the results of the autoantibody screen for a 45-year-old woman who presents with small joint polyarthritis. She is found to be rheumatoid factor positive. So what is rheumatoid factor? It could be an IMM MCQ, it could be a part 2 MCQ. You can get it in both the exams. See, the baseline medicine remains the same. Don't you think so? Some questions from the IMM can also be repeated again in your FCPS Part 2. Yeah. So what do you think is rheumatoid factor? Is it IgA? Is it IgD? Is it IgE? Is it IgG? Or is it IgM? What is rheumatoid factor? Rheumatoid arthritis, again, is very, very important for the exam, for your theory, for your talks, for your clinicals. Everywhere you will be getting questions on rheumatology. Yes, Dr. Amna, you're right. It's the IgM against the IgG. So the rheumatoid factor itself is IgM. So it's an IgM that is formed against the IgG. So very, very important to know that it's an IgM antibody which is formed against the IgG component of the body. So again, very, very high yield to know about the different topics, that if you get a question on rheumatoid arthritis, make it a point to go through these important topics while you're preparing. So if you've got a question on rheumatoid arthritis, see the diagnostic criteria there and then, see your clinical features throughout the body. Then you have to see the diagnostic testing. Very important to know which antibody is sensitive, which is the most specific, which you would be seeing before the disease onset, like anti-CCP could be diagnosed many years before the onset of positivity of rheumatoid factor. And then what are the treatments? what are the side effects of the treatment. So if you've seen rheumatoid arthritis, you should know about the DMARDs, what are the different DMARDs, what are the different other TNF inhibitors and all of the other agents that we use, and what are the side effects of these drugs. Extremely, extremely important. That is why it is very important that you make notes of at least all of the important systems, so that while you're preparing for the exam, you can always go back and revise those. And then the complications of rheumatoid arthritis. Extremely important to know about the eye complications, the respiratory complications, the cardiac complications. Everything is extremely, extremely important. So if you've seen any question on rheumatoid arthritis, make sure, keep that in mind that this question could be asked in various different ways. And if you've read a question on rheumatoid arthritis, make it a point to go through and revise the different concepts of the disease, so that if the next time you get a question which is from rheumatoid arthritis but asking you any other concept of the illness, then you would be able to answer that as well. So when we are doing our in our workshop, we will be studying. If we get a question on rheumatoid arthritis, I'll try to make it a point that we do revise some of the most important things that you should know at least for your IMM and FCPS Part 2, so that you don't have to go through the questions again and again. Okay, let's see the next question. Again, very, very important concept as far as the exam is concerned, as far as your clinical practice is concerned. You keep on seeing these cases every day, but as far as the theory is concerned, you still need to go through standard textbooks. See the question, and then I'll show you what is the important information in this question. What is the question actually asking you? So sometimes what happens is that you know the disease, you can understand, you can figure out the disease, but you don't know what the question is actually asking you to do. So read the question carefully, and then we'll see what the question is asking you. So we have a 58-year-old man who's reviewed in the clinic following a third admission in the past year with hepatic encephalopathy, despite taking regular medications, including propranolol and lactulose, and attending for surveillance endoscopy and variceal bending. The blood pressure is 100 by 70. He has mild ascites and pitting edema. So they're telling you that this is decompensated CLD basically. So the hemoglobin is 10, white cell count is 8, platelets are 85,000, sodium is 136, potassium is 3.8, creatinine is 89 micromoles. Please be careful with whether it's micromoles or it's milligrams per deciliter. Okay. Alanine aminotransferase ALT is 112 and alkaline phosphatase is 180. So what was the important information in this question? The important information was the age group. This was the third admission. So third admission means that this is decompensated CLD. This is not the first episode. So they don't want you to diagnose it. They already know the diagnosis. So the patient was already taking medications. Then now the patient has presented with ascites and edema. Now what else do they want you to know? So which of the following is the best way to reduce future risk of encephalopathy in this patient? So if you've come across any question of decompensated CLD, it's essential that you know the underlying risk factors for CLD, you know about the clinical features of CLD, when would you label it as compensated, when would you label it as decompensated, then the diagnosis, the criteria, the MELS criteria, the child-Pugh scoring, and then you need to know the treatment, the complications like liver cancer, you need to know about that as well. And so all of these things are extremely important. So what do you think is the best way to reduce encephalopathy? What do you prescribe to your patients when you're discharge a patient with hepatic encephalopathy? We do add something in their treatment regimen, don't we? What do we offer the patient? Which medication do we offer the patient? Do we offer clindamycin for long term? Or do we offer low protein diet? Or do we offer neomycin or rifaximin or terlipressin? Yes, Dr. Amna, you're right. It's rifaximin. We do offer patients rifaximin when we discharge a patient with hepatic encephalopathy. Dufilec is lactulose. Okay. So lactulose is just given to prevent the constipation. Okay. So now this is where your current medicine comes in. In current medicine, it's clearly written that rifaximin or ciprofloxacin or ofloxacin or norfloxacin, they are given to patients with hepatic encephalopathy in order to prevent the future episodes. So if you've studied, if you've gone through decompensated CLD or compensated liver cirrhosis, it's essential that you know of all of the latest guidelines, especially you should know about the treatment options and what are the different complications that the patient can develop. Hepatorenal syndrome, hepatopulmonary syndrome, all of these things are extremely important. You can be asked in any different way. So if you've come across any question of liver cirrhosis, like I told you, you should know about the etiology, clinical presentation, the diagnosis, what would you get on an ascitic tab, what would you get on an ultrasound, what are the different treatment options, how would you treat the complications, and how would you prevent the complications, like if it's hepatic encephalopathy, how would you treat it, and how would you prevent it? If it's variceal bleed, how would you treat the acute bleed, and how would you prevent it in future? If you have hepatorenal syndrome or hepatopulmonary syndrome, how would you treat it? So all of these things are extremely, extremely important. Are there any questions so far? Anything that is not understood or you want me to repeat again? I can do that for you.
Ma'am, for how long you will prescribe rifaximin?
Rifaximin is given long term. Okay. Okay. Next question. Okay. The next question. So you have a 65-year-old man reviewed in the emergency ward after admission with a renal stone associated with left-sided renal colic. The stone was passed successfully, although an initial abdominal X ray was negative and the stone was identified on an ultrasound scan. The patient is obese with a body mass index of 35 and suffers from hypertension and hyperlipidemia. Medications include losartan, atorvastatin, and his blood pressure is 145 by 88. A lot of important information that you're getting from the Viginet. So they're telling you that the patient had a stone, but that stone was not visible on the X-ray. So what does that mean? What kind of a stone is it? Is it a radiolucent stone or a radio opaque stone?
Resolution.
Yes, it's a radiolucent stone. So even by just looking at these first two lines, you're able to narrow down your diagnosis. So now you kind of know what kind of a stone could it be, right? Now the patient is obese. He has hypertension and hyperlipidemia, and he's taking two different medications. Now, what does the question actually want you to answer? So, what would be the most appropriate intervention to prevent the formation of renal stones in this particular patient? What do you think? So, what kind of a stone did the patient have, which was radiolucent? Uric acid stone. Very good. So, it was a uric acid stone. And how would you prevent a uric acid stone? Which of the following medications would you use to prevent a uric acid stone? What do you think? Which other drug would help to prevent the formation of uric acid stone? Which drug reduces the level of uric acid? Use it somewhere else as well. Yes, it's allopurinol. We use allopurinol for gout as well. So even if you don't remember from renal stones, you can always pick it that from in gout also you use allopurinol. So yes, it would be allopurinol. So the patient is hyperuricemia. The patient had renal stone that was visible on an ultrasound but not on an X-ray. So that means it was a uric stone. And in order to prevent the formation of recurrent stones, we would be giving these patients allopurinol. So again, very, very important to know about the different kinds of calculi, what are the different names, the different compositions, whether which ones are radiolucent, which one are radio opaque. The risk factors are very important. Which drugs promote the formation of stones and which drugs prevent the formation of stones, like thiazide diuretics. What are the role of the diuretics? What is the role of allopurinol? So all of the different drugs that you come across, and if they are associated with the formation or prevention of stones, so that is extremely important. And then the complications and management would remain there. So this was about renal calculi, that whenever you come across a question of renal calculi, that can be asked in various different methods. So even if you're trying to memorize questions from the past papers, that would not really help you, because now CPSP has made it a point of changing their question banks after every few attempts. So they are adding new questions into their pool, they're removing previous ones, but the core concepts would still remain the same. So you can be asked about renal calculi in different forms, but at the baseline calculi would still remain the same. Okay, now let's see another question from another system. Again, very, very high yield as far as neurology is concerned. You will definitely get questions from neurology. People are very, very afraid of neurology as a whole because they think that it would be extremely complicated. But let me tell you, the questions in neurology are fairly simple. You will definitely get a question on CNS infection. So you will be getting a question on um, encephalitis. You would be getting a question on meningitis. So if you know your encephalitis and you know your meningitis well, you would be able to answer questions. You will definitely be asked about stroke. We'll discuss stroke in detail as well. You will be asked about multiple sclerosis. Okay. Then you will be asked about um, pseudotumor cerebri. You will definitely get a question regarding that. So these are the few conditions that you will definitely get questions on. So if you know these few diseases very well, I'm sure you will be able to answer neurology without any problems. So you have a 65-year-old man who has type 2 diabetes and hypertension. He's admitted to the emergency department with sudden onset nausea, vomiting, and vertigo. So now start narrow down your differential. Start localizing the lesion. So the patient has left-sided Horner syndrome and a reduced left-sided corneal reflex and paralysis of the soft palate. So it's all on the left, and there is nystagmus and loss of pain and temperature on the right. Okay, so this is a stroke, an ischemic stroke. Now, what kind of the stroke? What does the question want you to know? So where is the lesion, or what is the site of occlusion leading to this patient's stroke? So you knew it's lateral medullary, you knew it's pica. So what is the lesion? Which artery is being affected? Is it the posterior communicating artery? Yes, Dr. Gul, you're correct. It's vertebral artery. It's the vertebral artery that is leading to these symptoms. So the patient has lateral medullary syndrome, and in lateral medullary syndrome, that is occlusion of the vertebral artery. Okay, so the blood circulation of the brain, extremely, extremely, extremely important. So stroke, you will definitely get at least 5 questions on stroke. We will be discussing stroke in a lot of detail as well. So the risk factors are extremely important about the preventable and the non-preventable ones. The location of the stroke is extremely important. The blood vessels, the blood supply of the brain, and the areas involved. If particular arteries involved, what would be the areas involved? Or if an area is involved, then what would be the artery that would be involved? The left and the right both are to be kept in mind. Then clinical manifestations. investigations, extremely important to know what kind of investigations would you like to do earlier on, what would you like to do later on. In a young patient, what would be the more important investigations that you would like to do. And then acute management and long-term management, again, extremely important. You should know about TPA, you should know about the window period, everything, all of that sort is extremely important. And then the control of risk factors. If they tell you that the patient is hypertensive, which kind of hypertensive would you use to prevent, to keep the blood pressures in control? What kind of an anticoagulation would you use? And the complications of each of those as well. So if you get a question on stroke, when you're sitting down to study any question of stroke, it's extremely important that you go through all of these points in detail, because you can be asked in various different ways. Okay, the next question. So you have a 56-year-old man of Pakistani heritage who comes to the clinic to discuss how to manage his diabetes during Ramzan, as he intends to observe the religious fast. So he's has type 2 diabetes for the past 5 years, and he takes metformin 500 mg thrice, and his BMI is 32. So, and his HbA1c is 54 millimoles. Okay, so how would you manage this patient? What would be the most appropriate um, schedule? Very good, Dr. Gul. So the most appropriate way would be that two-thirds would be given in the evening at iftari timings, and then one-third would be given at sehur or seri. So that is the regimen that you would be using whenever you changing the regimen for Ramzan purposes. So anything that you get regarding diabetes, again, very important to know about diabetes. You should know the pathophysiology, different modes of inheritance. You should know about diabetes type 1, type 2, all of the LADA syndromes, the maturity onset of the diabetes of the young. All of these are extremely important. Then management in particular populations, like management in the elderly population, management in the obese population, in the pregnant population, CKD, fasting state, extremely important. And you have to see the latest guidelines for that. The guidelines keep on changing for diabetes, for asthma, COPD, so you need to follow the latest ones. Okay. Then diabetic ketoacidosis, you must be knowing it's always asked on the exams. The diagnosis is asked, the treatment, the diagnostic criteria, the management, and when would you call it that diabetic ketoacidosis has subsided. Extremely important. Complications like microvascular, macrovascular, neuropathy, nephropathy, retinopathy, extremely important. The diagnosis, the treatment, and the manifestation. So if you have a question on diabetes, you can never say that this question was out of the curriculum, or it was out of the, it was not from the past papers. So the questions will not be repeated as per se, but the themes of the questions would be repeated again and again. Okay, so whenever you come across any condition which is as important as diabetes, it would be my sincere advice to make your notes and go through them in detail as much as you can. Not the nitty-gritty details, but at least the important things. Okay, now let's come on to cardiology. So you have a 28-year-old man who presents to the emergency department with central chest pain, worse on inspiration, and relieved on sitting forward. So now, even by looking at this straightforward one line, you know it's a 28-year-old man. So kind of you start narrowing down your differentials. Presenting to the emergency department. So this is something acute. Central chest pain, which is worse on inspiration and relieved on sitting forward. I think you have a diagnosis just by looking at this sentence. What is the diagnosis?
Myocarditis.
It's okay. between myocarditis and okay, take we'll see the other differentials as well. So he had a flu-like illness which began a few days before. Yes, it could be pericarditis as well. So he had been suffering from a flu-like illness a few days back, and he is also suffering from palpitations. So his blood pressure is 122/82, pulse is 75 and regular. So let's see what else they've mentioned. So which of the following would likely be to be seen on the ECG? So what would you like to see on an electrocardiogram? Very good. You would be seeing a saddle-shaped ST elevation. And how would you treat this patient? NSAIDs. Very good. So you give NSAIDs or analgesics in the initial phases, and if it does not subside, then you can go for steroids. Okay. So again, very, very important to know about the different diseases. What would be the differentials in each condition? Specifically, the conditions like hypertrophic obstructive cardiomyopathy, full Parkinson's, pericarditis. Extremely important to know about all of these. Myocardial infarction, electrolyte abnormalities, hyperkalemia, hypokalemia, hypermagnesemia, hypothermia. Extremely important to know about the specific ECG findings in different conditions. Arrhythmias, what are the different kinds of arrhythmias, and how would you manage each condition? Cardiology, on the whole, would not be very difficult if you can pick out the ECG finding and you know which condition is it associated with, or which condition is associated with which specific ECG finding, and how would you manage that condition. That would make your life very, very easy. If you know this arrhythmic pattern is seen in this particular condition, and how would you manage it? So that would just be that would be asked on your cardiology. That's extremely important. Okay, now we come on infectious diseases. So you have a 45-year-old man who comes to the emergency department with a wound on the left hand, sustained when he was separating his dog from another animal. He washed his hand soon after the injury, dressed it, and is to date with his tetanus vaccination. You can see three clear puncture wounds from the teeth. Sensation over the hand and muscle function appears normal. Which of the following is the most appropriate antibiotic intervention? Extremely important. Dog bites, animal bites, always asked on the exam. The prevention of the different, yes, Dr. Kul, you're correct. So whenever you have an animal bite, it's always coamoxiclav, because coamoxiclav is better when you have multiple microbes. So against dog bite infection, the best treatment that you can give would be coamoxiclav. Okay. And the most common pathogen that can be isolated is Pasteurella. So they can tell you about dog bite, they can ask you the organism, they can tell you about the dog bite, they can ask you about rabies vaccine. So different kind of questions you can get on from a simple question like dog bite. So instead of trying to memorize just one aspect of the question, it's always nice to see the topic as a whole. Then in infectious diseases, extremely important to know about the gram-positive, gram-negative organisms, antibiotics of choice for each particular disease that you come across. So if you are seeing typhoid, if you're seeing any particular, if you're seeing rabies, if you're seeing, and for antibiotics like meningitis, for endocarditis, for any particular illness that you come across, antibiotic of choice would be extremely important. For gonorrhea, for syphilis, extremely important to know the antibiotic of choice. Then vaccinations, very important to know which population would be vaccinated, who will not be vaccinated, especially if you have an HIV patient. So the CD4 count corresponding would be very, very important. And then specific population groups, if they ask, whenever you study any disease and you're studying about an antibiotic, At the same time, see what would you give in a pregnant patient and what would you give in a penicillin allergic patient. For example, you have a patient with infective endocarditis. What would you use in pregnancy? What would you use in penicillin allergy? If you have a patient with meningitis, what would you use in pregnancy and what would you use in penicillin allergy? Extremely important. You will always get questions out of these. Okay, let's see the next question. Now I'll show you how we would be studying each question when we go along in our main workshop. How would we be studying them in detail? This is kind of a question that we would be going through, and then we'll see how we will be approaching it. So you have a 74-year-old woman with a history of chronic lymphocytic leukemia, and now the patient is presenting with lethargy. So the hemoglobin is 7.9, and the blood film shows normocytic normochromic. So what do you think is the underlying complication? So yes, all of you are correct. It's warm autoimmune hemolytic anemia. So in patients with CLL, in patients with malignancy, it's the autoimmune hemolytic anemia that takes place is the warm type. Now, during a workshop, when we will be seeing questions, this is how we will be discussing them. So after every question, we will be going through the detail of that conditions. For example, we come across autoimmune hemolytic anemia, so we'll go through a little bit of detail of those so that next time, if you're asked from any other concept of that same condition, you will be able to answer that. So for example, when we are doing autoimmune hemolytic anemia, we will be studying about the warm and the cold types. So there are two different types. And autoimmune hemolytic anemia, the characteristic test that you would be doing would be the positive direct antiglobulin test, which is known as the Coombs test. So there are two different types of autoimmune hemolytic anemia. Type 1 is the warm one, and the warm autoimmune hemolytic anemia is the IgG. And all of the hemolysis that takes place is extravascular. For example, it takes place in the spleen. So most of the warm autoimmune hemolytic anemia, the conditions that are associated with it are autoimmune malignancies like CLL, SLE, all of these, and different drugs which lead to autoimmune hemolytic anemia. They're all associated with the warm autoimmune hemolytic anemia. On the other hand, the cold autoimmune hemolytic anemia is the hemolysis that takes place at 4 degrees centigrade. So the warm one is at room temperature, is at the normal body temperature, but the cold autoimmune hemolytic anemia is at 4 degrees centigrade. It's intravascular and the antibody is IgM type. And mostly the cold autoimmune hemolytic anemia is associated with infections. So it could be associated with mycoplasma, it is associated with Epstein-Barr virus. So you can get questions like, for example, they tell you that the patient had a pneumonia, and after that, now you notice that the patient's hemoglobin is decreasing. So what kind of reaction has taken place? So it's the cold autoimmune hemolytic anemia that's going on. So you can be asked a similar question in various different forms. So a little bit of summary of both the conditions. So warm autoimmune hemolytic anemia, the hemolysis is at room temperature or body temperature, while cold is at 4 degrees centigrade. Warm is IgG type, while cold is the IgM type. The hemolysis is extravascular in the warm autoimmune hemolytic anemia, and it's intravascular in the cold. And the associations are extremely important, that malignancies and autoimmune conditions are associated with warm autoimmune hemolytic anemia, while neoplasias, but usually the infections like mycoplasma and Epstein-Barr virus, they're associated with cold autoimmune hemolytic anemia. And the management is that in warm, you can use steroids and immunosuppressants and splenectomy, while the cold does not really respond well to steroids. So every time you get a question like that, you know the associations, you know the important conditions which lead to autoimmune hemolytic anemias and what are the different kinds of autoimmune hemolytic anemias. So when this is how we will be solving the questions during a workshop. And once we see a question, we will try to cover most of the information. That's a revision for all of you. I know all of you've trained well, all of you've done your IMM. If you're preparing for your IMM and preparing for your part two, so most of it would be like a revision, but it would be like a crash revision, that in a few workshops, in a few days, you would be able to revise a lot of your curriculum. That would have been almost very difficult to do if you're going through textbooks in detail. So I've tried to summarize the textbooks in the form of questions, so that once we see a question, you can always revise the entire topic from that in one go. Okay, another question. I think this is the last question. So you have a 21-year-old man who attends the emergency department after noticing blood in his urine. He's been feeling fatigued and generally unwell for the last 2 days and has been finding himself out of breath easily. His housemates had commented yesterday that he was turning yellow, but they had assumed that they was teasing him for being unwell. So he's normally fit and well. He's not on any medication. However, he started taking Primaquine for a trip to Tanzania. On examination, he is jaundiced and tachypnic. His urine sample is dark brown and it is positive for blood and bilirubin. He's afebrile and normotensive, and you're awaiting his lab results. So this is the lab result. So his hemoglobin is 11.5 or 115. His MCV is 90. His retic count is 2.1. And the peripheral film shows schistocytes, spherocytes, and bite cells. So what is the most likely reason for this presentation? Very good, Dr. Kaleem. It's G6PD deficiency. So now when we've gone through the disease, we know that this is G6PD deficiency. Now we'll go through a little bit of detail. What does G6PD mean? That it's basically the oxidation of G6PD to G6-phosphoglycerate. It's an enzyme that prevents the body from oxidative stress. So what is the underlying mode of inheritance? It's an X-linked recessive disease. And what are the different conditions which precipitate crisis? So it could be different drugs, infections. Most commonly, after a patient has had a viral illness, then they have this oxidative stress, and that leads to hemolysis. And then particular meals like fava beans. Then what are the different features? So the patient is usually asymptomatic, but during crisis, they develop jaundice. They have decreased haptoglobin levels because this is an intravascular hemolysis. And the characteristic feature that you see would be Heinz bodies. And the diagnosis will be made with the use of a G6PD assay. Then treatment would be to avoid the exposure, and then you have to, after the acute hemolysis has subsided, it usually subsides on its own. But if it's very severe, then you need to transfuse blood products. And then we go into a little bit of detail about what are the drugs that lead to hemolysis. So antimalarials, ciprofloxacin, quinine, nitrofurantoin, aspirin, all of these are the drugs that lead to G6PD deficiency, that precipitate or exacerbate G6PD deficiency. The drugs which are safe include penicillin, cephalosporins, macrolides, tetracyclines, all of them are safe. So this is how when we come across each question, we will be going through a little bit of the theory details also. And where also the important comparisons, like for example, G6PD is very similar to hereditary spherocytosis. So we'll see what is the difference between the two so that you do not confuse them. Like for example, on the blood film, you would be seeing spherocytes. The test would be osmotic fragility test, and the mode of inheritance is autosomal dominant. Gallstones are very common in hereditary spherocytosis, and a family history in parents and other relatives would be very significant. So this is how when we will be going through each question, we'll try to see why each answer is right, why are the other options wrong, and then we'll try to go through a little bit of the theory also in detail. So that's more of a revision session for you. And once we are done with the recalls, when you open your own textbook, you see that most of your content has been revised, and you can prepare very well for your exam in a very short period of time. So this was all about our FCPS Part 2 preparation, how you should approach the exam. I think the pattern of the exam has changed over a period of time. And initially, it was more of rote learning based, but now they've made it more conceptual, more in line with the international exams. So now it's become a little different. But it still requires hard work. It requires practice of the theory concepts and practice of the MCQs as well. So we would like to hear your opinions, any questions, any queries, anything that is not understood, anything you would like me to repeat, any input that you would like to give, any feedback about the session. For Is it enough to prepare for part two with step two USMLE? No, I don't think so. The questions are more in line with MRCP. Thank you, Dr. Gul and Dr. Nisar. Thank you. So for our workshop, you can contact our course coordinators. I think they're online and you are getting their numbers on your screen as well. So if you have any questions or queries, I'm happy to hear those. Otherwise, we can end the session. And we will be seeing you next Friday with our workshop. The day one of our workshop, we will be solving a lot of questions and we'll be going through a lot of core concepts, very, very important core concepts, all from the most recent papers. And then we'll be seeing the questions in detail. We'll be dissecting them. We'll be seeing each concept very thoroughly.
Maybe session कितना hours होगा, time इसकी होगी, इसकी तरह बता दे.
It would be in the evening and it would last around 2 hours, around 2 to 2.5 hours.
9 p.m. Same time.
I think we will contact all of the students and then we can set up a time, okay, which is feasible for everybody.
How many days it will?
Sorry?
How many days
I'm sorry.
it will be? How many days?
The entire workshop would go on for 2 weeks to 3 weeks, but we would be having live sessions in between. So we have 3 live sessions and then we have other sessions, study sessions as well. The details of the session would be shared with you by our course coordinators as well. Okay. So I think there are no more questions, so we can end the session for tonight. Thank you so much for joining. I hope it was a fruitful and an informative session for you if you're preparing for your IMM exams, if you're preparing for MCPS, or if you're preparing for your FCPS Part 2. And we will try to help you to clear your exam, to build your concepts, to refresh your concepts, and we will try to help you in clearing your exams. We will be seeing you again next Friday with our detailed workshop. And please contact our course coordinators for further information. I think the numbers are being shared with you. And then we'll be seeing you again. Good night. Allah